thanks for the invite. When Brenda asked me this like 6 months ago, I wasn't really thinking about it. And then, of course, the last couple of weeks, it's like, oops, I got to start making this talk. And then just came back from San Diego from our American College of Surgeons as well. So added a few more things to this talk. But main point of this is what, oh boy, here we go. Let's see. Well, it was working 2 seconds ago. I'm gonna just escape. Okay, I'll just click. It's fine. I don't need the pointer. So when I was thinking about this, it's like, what can I show or tell to a group of nurses? So I asked our nurses, like, what are the topics that you guys would be interested about robots? And then, of course, got a huge list. Most of them, like, why are we doing this? It's almost like a 50-50 split on this. So I'm going to go over what robotics really is right now and kind of tell you a little bit about the future. Whether you like it or not, this is here to stay, and more is coming. So if you think it's problematic right now, it's just about to get worse in the next couple of years. And why you need really a program. Just show of hands, is there a formal robotics program at your institution? Okay, well, maybe I should ask the other way. Anyone here that doesn't have a formal program? Okay. You may not know what the program is. The program could be just a surgeon and maybe the robot, or anesthesia robot. So it's kind of detail what a program could be. And then really it's about building a digital surgery team. It's not really about the robot, because for those of us that perform it, robot's actually probably one of the dumbest piece of equipment in the OR. There's nothing robotic about it, nothing automated about it, but the next generation systems are going to be fully automated. So what is robotics? This is a great slide by Roger Smith. He's like a PhD that follows companies that claim to be robotic. So there are 115 corporations out there that consider themselves as robotic companies. And it ranges all the way from head to toe. We all know about the juggernaut in the room, Intuitive, but you also have bronchoscopy robots, vascular robots, spine and knees with Mako and the Stryker devices. But there's also a hair implantation robot that's all the way up over here in the corner. But really, there's one for every organ, every body system. So if you're not really doing robotics, well, guess what? You may be, and you just don't know about it. Why? Well, someone always has an idea, and it tries to hit one of the 3 pillars. You want to try to fix a problem, make something better for a patient, or a better process for the team. They kind of come in all categories, from the ones which are basically just replicating surgeons' movements, just scaling them, all the way to full assisted guided surgeries, like for your spine surgeries, where it can take some imaging and then tell the surgeon exactly what to drill, or it'll drill it for you. Now, of all these 115 corporations, there's really only a handful that are FDA approved. So that's why we don't really know about it, unless you're actually following these corporations. So the big ones being Da Vinci, Senhance, your bronchoscopy robots, and a few more colonoscopy systems. But when I took that section that was on the right-hand side that are just for the abdomen, or for what we really consider for general surgery, really only 5 systems really FDA indicated. We all know about Intuitive. So for those of you who think that this is the latest and greatest, well, it's been actually around since 1999. That's when and before that, everyone kind of looks young in here, but ESOP, if anyone remembers ESOP, the device, it was a microphone control. What was that? ESOP. Yes, ESOP, look left, look down, and sometimes it'll work. You have to sit there and train it. I remember moving it for, as a medical student, moving it for the residents around. It was like a 50-pound device that hooked onto the edge of the bed. Well, Intuitive bought that company, so that was a big merger. I can tell you the whole history of DARPA and how it came out of the Department of Defense, but basically it's been around since '99. Currently, the 4th generation, which has been around from 2014, and then 19 when they came out with their single-site platform, the SP. Over 3,000 systems in the U.S. It's about 4,400 in the world. These are expensive, $1 to $2.5 million. For those of you who, if you're never sat on the console, you have to look at it. It's 3D inside the console. If you're just looking at the screen, it's just 1D, but it's still high def. Some sort of reusable instruments, and then it's really a primary replica technology. So meaning like if you open and close your jaws, that's exactly what it does. There's no automation, no scaling. Well, there's a little bit of scaling, but nothing automated or AI about the device. And here's a picture of the first system and the current one. Not much has changed except just more modular, easier to put together. Again, application started as a cardiac robot. So I've been fortunate to be at that hospital that had the #2 system in the world. So that's the main player in it. And then they realized urology, gynecology were the mainstay. So that's where it kind of stagnated for until the late 2010s, until general and all the other systems or specialties got involved. So bariatrics, general surgery is the the fastest growing sectors for robotics right now, because guess who does the most procedures? General surgery. But it's percolated to colorectal, oncology, thoracics, even ENT. Here is the SP platform. There is one, Emory Midtown has one of these systems for ENT and urology. That's the only FDA clearance right now, but colorectal's coming up, where you can do like transanal resections. It's 2.5 centimeter trocar, so 25 millimeter trocar, where 4 instruments can go in, and essentially they all bend. So you can have, this is true single site surgery, not like, well, if you've ever done single site gallbladders through the gel port. This is literally 1 trocar and 4 instruments. The rest of the system looks the same, console, everything else. This is the true competitor for Intuitive, but no one in Georgia has seen this because only 6 of these are deployed in the US. The Synhance system, basically each arm is its own platform, so it's about the size of an X or XI. So imagine how much space you need in the OR and how much movement you have to do. The beauty of this is it really replicated laparoscopy, so all the instruments look the same. You're just putting laparoscopic trocars in, and the console you're like sitting with goggles on. So it's a kind of like a hybrid to what the newer next gen systems that are going to come out. This is a Robotics Flex. So these are all FDA approved, so they exist right now. This was more of an ENT robot. The only thing robotics about this was the camera system, so it's more like an endoscopic system. But the instruments were just flexible instruments. So if you want to move left or right, it's kind of like the opposite. You want to bend your arms a different way. This is about $1 million system, so didn't really get too popularized or adopted. They do have transabdominal indication, meaning like you could do surgery through the belly. But again, it's a very novel device and not very popular. This is where the battle is going on right now. Battle of the bronchoscopy systems. The system on your left is the Johnson & Johnson RS Monarch system, and the one on the left is the Intuitive Ion system. Essentially what it sounds like, it's a fancy bronchoscopy system. It's 3.5 millimeter device. So think about your ureteroscopes. How small they are, that's what it is. And it goes through your trachea, or go through your mouth, into your trachea, into the bronchus. So it can actually go further down the lungs than ever before. The point of this is for diagnosis, treatment, and well, diagnosis and treatment basically, because you can actually get a sample of the tissue. And right now what's actually going on is you can actually do the diagnosis and the treatment at the same time, meaning like you can do the bronchoscopy. Let's say there's a lung lesion, do the bronchoscopy, get a sample, give it to pathology, and if it's malignant, in that same anesthesia, dock the XI system and do the lung resection. So I think we're around about the 70 mark right now, 70, 80 mark where we've done this in one anesthesia, one procedure. Basically, you get the diagnosis and do the therapy at the same time. But the way I think about it is like, if your camera system can be 3.5 millimeters, imagine where we're heading with this technology in the future. So again, we're just kind of touching the tip of the iceberg as far as what the devices are. Here are some future ones. This is probably the closest one to competing with Intuitive. This is a CMR Versius robot, currently deployed in South America, Europe, India, and actually has backing of the NIH of the UK system. So it's one of the only systems that they promote as far as cost-effective, efficiency, everything else. So it's basically take the Synhance machine, which was each arm was its own robot, 18-inch by 18-inch devices. So each arm, that's the platform. So if you want one arm, you can do one. If you want 5, you can bring 5 of them in and just surround them around the patient. But it's very similar to laparoscopy, same trocar. So basically, you don't have to use as many specialized instruments or specialized devices, so easier to learn. Of course, the major competitions, they're making their own robot. So this is a Medtronic's robot. So Intuitive is about I forget how big the company is, maybe about 20 billion. Medtronic is a $150 billion corporation. So they made their own robot. Their whole premise is, think about the hurdles in the OR. If you have one stapler versus a different stapler, you get the wrong load, wrong size, doesn't fit. Well, their thing is, well, you can just use all of our existing products on this robot. So you don't have to, it's a little bit more efficient, less, to where I'm looking for, less variability when you're in the OR. So you don't have to use as many things. And then of course the Google robot, which is funny, Google actually backed out of the deal. They sold their shares. So J&J and Ethicon are the only ones running it. No one really knows what it's going to look like, but it's going to be a digital system. It could deploy from underneath the bed. So meaning like it could be attached to the bed, and if you need the robot, it just deploys from underneath there. There are some few prototypes. That's what their patents are holding. But we won't see this one until maybe 2027 or so. Even the Medtronic robot is not FDA approved. They've been delayed to about 2023 or 2024. So alternatives, I show these because this is all considered robotics as well, and another hurdle to deal with in the OR. Oops, let's see if I can go back. So this is the FlexDex dispose system. So basically it's like a cuff link the surgeon wears, and then you switch instruments out. It's basically a hand motion instrument. There's nothing robotics about it. It's like gears and levers. It basically mimics surgery. It kind of adds that flexure that you're missing for robotics. It's a disposable device. It's about $600. There is a little bit of a learning curve. They show goggles and everything, but that's just like using an Olympus 3D system with this. This is now adding that and making it more digital. This adds a power pack to the end of it. This is about a $50,000 device with a battery pack, and you just switch the tips out. It's what he's using on his right hand, and basically does the same thing, but it has a motorized grip, and it will actually turn the device. And then I think here they were just showing this fitting into a regular 5-meter turn. So again, you don't need any other specialized equipment. It's just a handheld device. $50,000. I think each instrument is another $100 and something. Then you change it and take all the robotics out of it. This is artisanal. Now this is, you can actually get this right now. This is FDA approved. It might be on your shelves already. It's a disposable device, another $600, $700 device. Each instrument does the same thing, but this is more intuitive in the sense that if you want to move right, it moves right. So it's not like Flight Simulator where you're trying to figure out which way to go. But each instrument is a disposable device. So what's on the horizon? So why do I show all this stuff? So this is coming down the pipeline. Robotics 5 years ago, 10 years ago, it wasn't really, it was like a specialty device. It was like, oh, this is what the urologists need for their prostates. Well, now if general surgery, bariatrics, oncology, everyone's using it, it just opens up the field. So it's going to get cheaper. It's going to be more standardized. So less variability, less things you have to worry about in the OR, and it's going to get smaller. So which is one of the big things we want, right? Imagine what, well, the Da Vinci system hasn't really changed. It's still the same size, but it's gotten a little bit slimmer, but not really much smaller. But that's what the newer devices are. Here is the robot that's going to the space station next year. Actually, no, the surgeon that's the co-inventor for this, it's the virtual incision one. The actual robot is that thing in the middle. It's a 2.5-pound robot. It's semi-disposable in the sense that you use it 10 times and you kind of throw it away. It has its own like ESU, own console, but this is what they're shipping to the space station because it's 2.5 pounds. It does work. It's a single side robot, so you have to make a small 2.5 centimeter incision. You dock it, and then the instruments, when you want to change it, you actually pull it out and they screw on, screw off. It's going to incorporate, ooh, that went fast. The next stage is going to be incorporating existing data. So taking our CT scans, all the imaging, all the data that we already have, and then overlaying it. So make the actual device a little bit smarter, or at least give surgeons and the OR teams a little bit more information, so you can do targeted surgery and really offer minimally invasive operations. And then what's really coming down the pipeline is what we really noticed is there's a lack of education around all this stuff. So right now there's only one company, really. What happens when you have 5 different devices in the OR? Who's going to take care of all this stuff, or how are we going to learn all this stuff where basically it's just handed down to you? So there's going to be more simulation, either virtual or actually on hands-on. There's going to be some training pathways or curriculums that are going to come down the way. And again, most of this has been directed to surgeons and the trainees, but then it's not even the horizon. That's what we're doing right now, is actually incorporating the entire OR team in all these simulations and the pathways. And then eventually there's going to be some guidelines for this. You know, things that happen in the laparoscopic world. Now it's like, you know, it's second nature to do all this stuff, but for robotics, there's still that stigmata that you have to have some sort of maintenance credentialing, especially when you have multiple devices and manufacturers vying for the same space. So this is just, you know, just some curriculums. If you're on the intuitive ecosystem, as they call it, you know, they have fancy words every day, but some curriculums you can do online. The training opportunities, believe it or not, there are actually a lot of groups out there. This is Facebook. The Robotic Surgery Collaboration has 15,000 people on it. It's not just surgeons. In fact, a lot of them are OR nurses, surgical techs, OR staff, and they'll ask questions. I mean, just last night there was a robotics coordinator, a nurse, asking like, what are you guys doing? Are you guys noticing glitch on the staplers? And then immediately within like 5 minutes, there were 100 responses on it. So it's a good avenue to connect with everyone else in the world, because the problems you may have, you may think it's isolated, but it's not. It's actually kind of global. So it really connects people. SAGES has a bunch of societies. Most of them are surgeon geared, but again, the push is now is to try to incorporate as much of these the groups together, because it's not really about the surgeon. And of course, there's gonna be some specialty courses for the OR staff that are already online and should be available if you request it. So the next phase is like building a program. So in the past, it's been always about the surgeon, trying to sell the device to the surgeon, but really not to the team or really, you know, to the entire program. So what does a program look like? Like I joked before, it could be just a surgeon and a robot, and then everyone else has to kind of learn how to use it or kind of fall into place. But really, it involves everyone in the process. Surgeons, anesthesiologists, the techs, OR nursing, still processing, scheduling, because if you have multiple, what is it? Well, is that Joyce? Yeah. Well, she's our puppet master, but it's anyone that deals with the robot indirectly or directly should be involved. Of course, administration, if you're a big enough program, you might actually need someone full-time to run the program, to make it more efficient, and also deliver the highest care possible. And the main purpose is to have unified goals. Everyone's in their own little bubble, in their cocoon. The surgeon's trying to figure out, I need to do more cases, or why is this not working? Why do we not have all the, why, right? And the circulating nurse is just trying to figure out, like, why is it not even turning on, right? Because the goals haven't been defined, and no one's been really working as a team. I do 24/7 cases, but I know how to disconnect the robot and plug it back together. At our facility, we unfortunately have multiple systems that just fly back and forth between departments, but I can turn it on, plug it back in, but some of my partners can, or some of the other ones can't. So what do you do in those situations? And the whole point of having a team is you sit down together and figure out what are your individual problems. This is what we did 10 years ago. Now we're more in the data collection process. We're reviewing cases for quality. Listening to our staff in the OR, it's like, we had this problem, or, ooh, this part didn't go as smoothly. What can we do better? And the whole point of it is to emphasize patient safety and outcomes, right? That's what we're there for. And we should work as a team to figure out what are our individual issues. And, your issue could be like, I don't know how to turn it on. Or it could be, it's like, how can I sneak in the 5th case that day? So I looked at the AORN website and I say, all right, I know what my nurses do. Seems like they do everything. But I also heard the gripes that we have, like, why are we not doing cases on the weekend? And I'm not talking about elective cases, just emergent cases. And then I look at, like, all the responsibilities, like, oh boy, no wonder they're just running around all day long. This is straight from the AORN's website, but this kind of includes everyone, all the nurses, from peri-op, intra-op, post-op. So then I dug a little bit deeper, and here's what the inside the OR looks like. You have your scrub nurses, your circulating nurse, which, I'll do anything they tell me to do. And then, wow. You guys don't know me that well. And then, of course, our first assist, which could be nurses or PAs, but basically everyone has their cocoon. But if you look at the common theme, it's basically taking care of the patient and making sure the room is working well. And then what do you do when a robot jumps in? This is one of our exits, which none of us really like. We named it Bam Bam, but essentially it's like Bam Bam. Just comes in, crushing into a room. It's like, how do you bridge that gap? Because I think one of the biggest hurdles is like lack of training, lack of education, and then lack of continuing that process, especially when these devices get upgraded or they throw in the next generation generator and then we don't know which one to plug it in. How do you bridge that gap? So, this is one of our other ones. Brenda likes WallE, but I just decided to highlight all the ones we have. Number 6 is coming, and I think the code name right now is Khaleesi. So we'll see what happens. But I think of this and the nurses when we sit down and have our group meetings, and this came out from just even a couple of weeks ago when we're trying to do cases on the weekends. Like, what are the concerns? And the biggest concern seems to be like, what do we do on a weekend if something doesn't work? How can we get more training on this? Because during the daytime, you have all the staff in the world. You have the team that's very robot facile, and then sometimes it could be the orthopedic team that comes in. So how do you bridge that gap, and how do you get everyone trained together? So before, that's the best GIF I could find about just an OR nurse. I mean, it's incredible. There's a pre-game plan. You're preparing the robot in the console, which I don't know why we have to actually do that. At this point, it should be just turn on and turn off. Preparing the room, essentially to lower the functional barriers, because again, the better job we do it in the pre-op phase, the smoother the case will run. So less running in and out of the room, say, oh boy, we don't have this, we don't have that. And essentially, it's to ensure the patient's safe, because when you do leave the room, and this happens quite a bit, it's like, I ask for something, so first thing I'll say, I don't need this right this second, put it on a list of things to get by the end of the case. but then it always happens that they have to run out for something else and then say, hey, I need this, and there's crickets, because in robotics, everyone's disconnected, right? It's not that the surgeon, all the entire team is at the patient's bedside. The surgeon's actually in the corner somewhere. And if you've been to some programs, sometimes the surgeon's not even in the room. There are some setups where the robot console is outside the room. And yes, they could be running multiple rooms, multiple consoles from a control center. I can't show you those pictures, but there's a lot of things that are going on. And again, that's what the robotics were constructed for, was to do remote surgery. And guess what? That's already been developed. It hasn't, the 5G networks are just getting online for that. So imagine if the surgeon's not even in the room, what's gonna happen? So then you have to switch roles when this case is actually going on. Now you're in charge of troubleshooting the robot. Who has had training on how to troubleshoot the robot? Yeah, not that much, right? It's like once a case gets started, you just kind of keep your fingers crossed, nothing happens. But on the surgeon side, we actually get that training. The question is, who pays attention? I've never used DV stat before, because if there's a troubleshooter, I just scrub right back in and figure it out. And even my PA's bedside team is trained to do this. And even our nurses, but again, it's two groups. The ones that are fully trained, or three groups: fully trained, somewhat trained, and robot naive, and trying to get everyone together. But again, the goal for the staff in the OR is to protect the patient. And this is where the divide happens, right? Either you see value in robots or you don't see value. And it's funny, even in this day, in 2022, we're still debating this. I can understand it 10 years ago, but now, I don't have that latest slide that I saw earlier this week. Robotics has taken over. It's at that cross line where it will probably be more than laparoscopy, which is basically, that's what it is. It's laparoscopy 2.0. So if you see value, you see it's better for the patient and the staff. And these are quotes from the staff, because if you run a lean program, you may not have as much equipment open. Think about if you're doing inguinal hernia. You really just need a Mayo stand. You don't need like big trays, less things to count, less things that are contaminated. And the robotic instrument is all kind of packaged individually. There's less equipment needed, less variability if your program actually runs smoothly. And that's part of the thing together. It's like, actually nurses know this better than even surgeons. Like, you know what, surgeon A, B, C, and D do it all differently, but in reality, they could just do it all together. So we take that input, go back and change our pants. But if you don't see value, all you see is this big contraption, bulky equipment, more setup is needed, which I'll argue less setup is needed, but I get it. There's more things moving around. Another thing to learn and manage, and I put in the babysit, because that's a term that everyone kind of talks about. It's like babysitting the robot again. It's like, well, I kind of get it with a 5-year-old, but at least it doesn't talk back. Actually, there's a mute button. It does talk back. You can mute it on the patient card. And then surgeries take too long. This is the national debate. You know, what are the benefits to the patient? You know, it's going to take another 5 years for studies, just like the studies on smoke and everything. We know it, but you always need some sort of randomized controlled trial to prove anything. But at the end of the day, I say the train is departing. Depends where you are. 24/7 robotic surgery is on the horizon. It's actually already here at some of the more facile programs. So imagine, think about 20 years ago. Would you consider doing a lap appy at like 3 in the morning? Probably not. Would you consider it now? I would actually probably say no, don't do it, because the data shows just wait for the morning team to do that. But if something was needed, like if I have dealing with a bowel perforation, no one second guesses me when I say it's booked laparoscopically, because they know what's going to happen. That patient's going to probably do better, probably leave the hospital in a day or two, versus if I open, they'll be there for 5 days. But why not robotically if you can perform the same thing? More complex / open surgeries are being performed robotically. Whipples are being done. Yes, they're taking 12 hours, but if you go to the high centers across this country, they're done in 5 - 6 hours. Why? Well, the patient does better. They leave the hospital quicker. The leak rates, I'll be honest, the leak rates, everything else is the same, but the patients tend to do better. Personally, I do these big complex ventral hernias, and if I do them open, sure, I'm done in 3 hours, but they're sitting in the hospital for a week, versus if I do them robotically, it may take 6 hours, but they're home the next day. So which one would you prefer? There are trauma centers doing robotics on trauma patients. Grady's not there yet, but Methodist, Chicago, there are a handful of places that are doing robotic, like stab wounds, so splenic ruptures. So it's there. Why? You can see better. As long as the patient's stable, you can actually get away with it. And then the training, it has to be more focused on the entire team. And I think that's the biggest push that we're doing at our facility, is train everyone, whether they like it or not. Because think about it, what if it's you on the other side? What would you like to have done? Anyone can do open surgery, but would you like minimally invasive surgery? So if you have that mindset, I think everyone will be on board. And then of course you have to have champions that are leaders and actually willing to conform, right? Not the old farts. The other thing is, I think about the nurses that are graduating, or the staff that's graduating. They're not really getting the training, and then they're thrown into this. So we kind of have to impart that knowledge on our graduates. Just what we're doing for our trainees in my surgical trainings, like every resident graduates with some sort of robotic exposure, because you never know what they're going to get into later. Doesn't mean they're doing it well, but at least they know the basics. So the takeaway for this, and this is what my staff said, it's not just the robot, it's a device. It's the same way we think about laparoscopy or any other procedures. It's another device. Define and grow your roles. And I say this because, would you like that handed to you? Because that's what happens to me right now. It's like I'm just told what to do. Or do we take one step ahead and try to do it ourselves, define it and grow it ourselves, especially with digital surgery technology as it grows. Be vocal and a champion, because for your patient, that's what, that's one of your pillars in nursing, is like, you're there for the patient. You're not there for me. You're not there for any other person. You're there to protect the patient. So be vocal and be a champion for them. And then prepare to train the future, because that's one of my biggest gripe, is like, we have to keep our senior staff on staff, because the next generation, where they're learning from, you have to learn it from the ones that have already gone through it, have already gone through the hurdles, and impart that knowledge to the future. And I think we have to do it like yesterday. We have to take that knowledge and spread it around. And what a better way to do it through your own society and through programs like this. And then this is normally what we're doing on Saturday mornings, but she does hers, I do mine, so keep them separate. But all right, I finished early. I was trying to keep us on track, but I finished maybe a little too early.
So we have plenty of time for questions.
Yeah,
for Dr. Patel, and we could also bring Brenda, Christopher, and Pat back up for the questions like we have. So we do have time to do that.
Yes, I totally agree. I
for Dr. Patel first, though.
Yes.
One is, what is the environmental impact of some of these disposables? Because we're all into the environment, trying to preserve the environment, and as we see where we're trying to reduce carbon footprint on some things here in the medical community, is like disposable. So these are big disposable items. These are not just plastics that we can fry a long time drive. So what is it that the responsibility of the robotics companies and initiatives to reduce the impact on our environment? That's number one. Number two is, as the physicians are becoming more and more regenerative in the future, where is that collaborative experience between the circulating physician to ensure that they're prepared for your case and they're in the room and you're responsive to your needs when you have to do things? Because I see that if you don't have the communication with our colleagues about the things, nurses are more reluctant to speak up or speak out on the plan appropriately. So, very good that type of innovative communication, circulator, in charge of your room, setting it up, and the physician has to do it.
Yeah, so the first question is great. So that is actually one of the biggest debates right now, is that the environment and then how eco-friendly are we making this stuff. Unfortunately, a lot of things are going disposable. I mean, even like EGDs, colonoscopes, all the scopes, they're pushing for disposables. Why? One, the biocontamination, the lack of staff, lack of training to even clean things properly, because that seems to be our biggest focus. It's like eliminate the bioburden. But for all this, you're right. I look at the trash that's generated after a robotic case, and it just makes us cringe. A lot of these devices, so one of the new things the newer companies are doing is more reusable instruments or reprocess instruments, meaning like they're just mechanical devices. Why can't you just clean them and repurpose them? That's what happens to your ligatures and your harmonics. The problem is the FDA has a provision in there that you can only do certain devices that are reposable. So what happens is these devices get sent off to other countries, South America, India. Not like they're any worse, but these are unfortunately the guidelines that we're stuck with. But we have to push for that, and that's the things that we're pushing from society. It's like, okay, that's great, you built another robot. Can you make these a little bit more eco-friendly? They can be sterilized. We don't need fancy drapes. Like you look at the robots, think about all the drapes. The draping alone takes up a garbage bag, and it's plastic. Are we recycling them? How many of you have a recycling program in your ORs? Right? We're talking about all this other stuff. That's the easiest thing to do. And we had an initiative a few years ago. One of our anesthesiologists was big into it, and basically set up all these bins in the OR. Then we can figure out who's going to clean the bins. I mean, it was like basically we did it in silos instead of coming together as a team to think about it. But you can recycle probably 80% of the waste in the OR, but I guess there's not much money in it. And then recycling, if it's one, if you throw in one bloody Raytech or something in there, you have to throw the whole thing out. So that bioburden kills us. So I think we have to do it. The companies are not going to do it. The companies are just going to keep putting out this stuff, but we have to be the educated consumers on it. Your second question about building the teams. That's how I was trained. I still show up at 6:30 in the morning and I make a list in the OR. Like I literally come in. Now the assignments are made at like 7, so I come in at 6:30 and I'll write my list. Then I'll go see the patient. Just because the checklist, the pick list, we just switched to an Emory system, a new one. We're day 22, as I call it. Still chaos. My gloves have changed magically. But I'm not a wasteful person. This is all I need, and that's all I need for the whole case. That's it. Not one bit more, not one suture more, unless something else changes. Even then, I have a few backups in it, but this is all I want open. I have screenshots of my back table, and I actually gripe when it's too much. I was like, I just want one Mayo stand. That's it. Trust me, I don't need anything else. But I do that, and that's how I was trained in my fellowship to do that too. Like take ownership and then work as a team. I don't think that's how the last generation or even the current generation's trained. So you might have to just put up some barriers, not have anything open on time and then see what happens. I know there's a lot of shaking heads, but right now it's like, what can you do? I'm chief of surgery, so all I get is all the gripes. And it's like, so what was your plan? You go in there and tell them that you're doing this case instead of how it's posted on the screen. And then they grumble, say they should know. It's like, how? If you don't communicate, how would anyone know what you're actually going to do? Your H&P is always late. Sorry, I was getting on my little stuff, but it's like your H&P is late. You didn't show up. You didn't mark the patient. It's like, how are they going to get ready in 10 minutes? And then we have sterile processing issues where they're sending the wrong scopes, and then the nurses are running around and teams running around trying to gather all the supplies. You can't do that, especially in this era with not having enough staff. You have to learn lean. You have to run leaner and more facile with this. So I don't know how else to do it. Yes, Joyce.
We have people who know this, we try to have team surgery and stuff. They kind of know your team, so that's.
Yeah, I agree, and you help with that too. So I have to give Joyce and Angeline, who's kind of like staring at me right next to her. But no.
Most robot things, when you only have that's a challenge.
Yeah.
But we are lucky enough to have robotic director. We also have a robotic coordinator who needs to get certified tech. So that does help our robotic program. Yes, we work to say. But I will tell you, very clean person is not lying to you on that matter. It leads to efficiency, so it does help the process have that support of your team certified.
We appreciate you being a proponent of trying to get the team to be this way. You just need to get all the surgeons to feel this way, to be part of that team effort, because we appreciate you and the surgeons that do have that in their mind and their actions.
Well, thank you. Again, you have to push us a little bit too. So don't be afraid. And someone mentioned about not speaking up. Please speak up. Like, your voice has to be heard. Your voice is equal to anyone else. So you have to speak up, because that's the only way we're going to notice that there's problems and there's changes. Even the smoke evac. I don't do a case without smoke evac. And it doesn't impact, I'm sitting in the corner, but I have a team right at bedside. So even that little filter is on there. And even if it's a 5-minute case, it's like, where is my filter? We're not doing anything until that filter's on it. But we're not even using energy. I don't care, put that filter on. But the pencil ones are a little problematic. And I agree. Someone needs to just make one where there's no variability. I don't even believe in the 5. Just make one that works and just have it standardized.
Well, thank you very much.
Thank you. Thank you so much.
We definitely have time. You want to come up for 10 minutes to answer questions, your last talk? There were some questions in the back related to the last talk. Yeah. Brenda, come on up, and if you need to have the others are right down the front.
Yeah.
I'm just curious, is there an implementation deadline? And so is there a time for the amount of hospitals that they don't follow it? And also, the staff members start getting symptoms. I know now that it's law, are the hospitals now going to be liable, or is it workers' comp, or how do they figure that out?
Your first question was there an implementation deadline? July 1st was when it took effect. There was no stipulation in the law for any lead up. So as of July 1st, all hospitals were supposed to, and ambulatory surgery centers were supposed to have a policy that is designed to protect staff and patients from inhaling surgical smoke. How that is done is up to the hospital. That's where you go to your guidelines, and specifically ARN is one. What was your second question?
Is there a penalty if they don't?
That was the point that I was trying to make. Currently, there is no penalty. My question to the Department of Community Health is, if they go in and find that the hospital has a policy or does not have a policy, but doesn't use it, or does not have a policy, will their record be noted? And I've sent emails September, October. I have not gotten a message on that from the Department of Community Health, but it almost has to be noted in the hospital records that they either did or did not have a policy. What I'm trying to work on right now, and it's been like only started to gel in my mind yesterday, was a one-page algorithm that we can use in hospitals that here's the law, and if you have a policy, not use these steps. If you don't have a policy, these steps, and just different ways that you can do to work out what the next steps are, including the different departments. So say, for instance, you don't have a policy, your hospital gets surveyed, it's noted in their record, and then Medicare comes into the picture to look at some situation regarding reimbursement of Medicare. And maybe it is somebody who has been experiencing symptoms in their own facility has filed something with employee health. Or Pat was saying that it's going to take a class action lawsuit somewhere. Angela Hahn is here today, who has lung cancer, and her physician told her that it was likely related to all her years of working in the operating room. So it's still in the developmental phases, and all I can say is as soon as we collectively work out some method that works for individual hospitals, then implement it in other places. But it's going to take all of us. And I think you had a third one, and I don't remember what that.
If you have symptoms.
Oh yeah, you know what? I wish that I had. I mean, I worked at Emory when we did the electrosurgery ablation of the external venereal lesions with the Bovie. I mean, 5 years I breathed that with no smoke evacuator. So did it contribute to my adult onset of asthma in 2012? I think it did. Can you prove it? No. But there are some randomized clinical trials now that have been published that I think are quite good. And my question to the hospital would be, how much do you need to know to it's not good for you? It should be intuitive, and I don't understand why it isn't.
Right, but now that there is a law, if they're not doing anything, people start exhibiting symptoms or
Yeah. You know, if you're sick and you go to your employee health and you fill out an incident report or any of those sorts of things, the minute you start that process in your facility, then to me, you make yourself a target. And do you call the community health department and say, we have a law that my hospital is supposed to be evacuating smoke? We are not. So you have to think down the road, if I do this step, then what is going to happen? And like I said, my question to the hospitals is, what is your tolerance for risk? Because eventually that will happen. Eventually somebody is going to take the step to do a class action lawsuit, take on a hospital. And that was my question to some people who've had issues. Did you file for workman's comp through the hospital? Because those kinds of documenting those kinds of occurrences is the only thing that's going to help give us some hard, fast information. The problem is it's not exposed to the smoke and a week later you have symptoms. It's long term. It's cumulative and additive to a person's system, and that's what one of the issues is with smoke evacuation. We have the law. We have to determine the best way to get it implemented in the state of Georgia. And anybody who has any ideas, any input, so much of what we did was based on making connections with people in the right places. Somebody knows somebody. And those connections among people is what allowed us to move along in 3 short years. So keep your nose to the grindstone and help us help you and make it a reality in all of our hospitals, not just the bigger ones.